Hello, my name is Donna Cryer, and I am the CEO of the Global Liver Institute. And I have the distinct privilege of bringing to you this GLI International NASH Day panel on NASH and liver cancer. NASH, otherwise known as non-alcoholic steatohepatitis, is a serious disease with more than 115 million people around the world being affected. Approximately 2 to 12% of those patients with NASH go on to develop liver cancer. Liver cancer, particularly hepatocellular carcinoma or HCC, has a survival rate of less than 20%, less than 1 in 5 people. So as the Global Liver Institute leads this International NASH Day, convening doctors, medical societies, patient advocacy organizations, and the type of experts that we'll bring to you on this panel, we are very excited to highlight this particular issue. And so we also want to give a very specific thank you to all of those organizations who have endorsed or supported International NASH Day in some way, particularly the American Association for the Study of Liver Diseases, AASLD, and EASL, the European Association for the Study of the Liver. But we really thank all of the medical societies from all over the world as we bring you NASH around the world this year, who have been working with us on this event. And so now I have the distinct pleasure of introducing our experts, our guests for today on this issue of NASH and liver cancer. We have really someone who needs no introduction, but I will introduce him nonetheless. Dr. Scott Friedman, who is the chief of the Division of Liver Diseases at the Icahn School of Medicine at Mount Sinai in New York, United States. We have Dr. Elisabetta Bugianesi, Associate Professor of Gastroenterology and Hepatology in the Department of Medical Sciences at the University of Torino in Torino, Italy. We have with us Dr. Luca Miele, who is a hepatologist in liver transplant medicine at Gemelli Hospital, Catholic University of Rome in Roma, Italy. And we have also rounding out this fantastic, very Italian panel, I would say, very excited to say, Dr. Giacomo Germani, who is a board member of the European Society for Organ Transplantation, the European Liver and Intestine Transplant Association, and he's coming to us from Padova, Italia. So ciao to my panel, and thank you for joining me today.
Pleasure to be here.
Thank you.
Thank you. Thank you so much for inviting us.
So my first question, starting with Dr. Friedman, is as we sit here in 2021, it has been quite the year. Several changes from our discussions about NASH and liver cancer last year on International NASH Day. And so what has liver cancer been like in the age of COVID?
Well, I think no one has been spared of the enormous impact of the COVID pandemic, not patients, not physicians, not our societies. A couple of things are worth emphasizing that are more or less COVID specific. One is the fear of patients who are not infected with SARS-CoV-2 to go to the doctor. And so across the board, medical care has suffered because of a reluctance of patients to see their physicians, to engage in routine screening, and certainly to address specific symptoms as they arise. Now, I have to admit, I haven't seen any specific data with respect to cancer diagnosis and cancer screening in liver, but I suspect it will follow along with other diseases where screening is so urgent, and those have lagged as a result of the factors related to COVID. A second major impact in our world in liver has been the enormous surge in alcoholic liver disease. And that's easy to rationalize if we think about the enormous stresses that the pandemic has wrought on all of us. the lack of access to counseling and support groups for those who have histories of alcohol abuse, and the tremendous impact of excess alcohol, not only on the development of alcoholic liver disease, but in those who are obese and may have underlying NASH, the synergistic worsening of liver disease due to alcohol added on top of NASH. So those are a couple of the major impacts. I'm curious to hear from my colleagues in Italy what their experience has been. Certainly, we're not out of the woods, even here in the US, where vaccination rates have picked up recently. And there are also some major highlights experimentally that are unrelated to COVID that I'm happy to address after we hear from the other panelists.
Thank you so much. That has really been our input from the patients and caregivers that we're in touch with in the US and around the world, and certainly as liquor stores stay open, but churches and other methods of support stay closed, it has been very difficult for patients to cope. And I know that we are trying to tease out the differences between alcohol and non-alcoholic liver diseases, but as you say, they compound each other. Dr. Bugianesi, your take on liver cancer in the age of COVID?
Yes, I can agree. I mean, with all Scott was saying, I must say that COVID had a big impact in two ways. The first is increase the high-risk population. So there has been an increase in obesity, in decompensated type 2 diabetes, in decompensated people with cardiovascular disease. So the patient that I see now compared to the patient that I saw 1 year ago are definitely more obese, with more advanced type 2 diabetes, less controlled type 2 diabetes. And this is a problem because we know that hepatocellular carcinoma in NASH arise not just from cirrhosis, but also from the synergy of several factors, including the carcinogenic potential of obesity and diabetes per se. Obesity and diabetes per se can increase the risk of HCC by 2.5 times each. And if you are obese and diabetics, then the risk is fourfold higher. So this is the first consequence. I must say that the lockdown has played, has had a great impact on that, because I can remember that during the lockdown, most of the advertisements were on food in TV. So what people was doing, it was just eating while waiting at home that the lockdown was going to end. And I mean, I know that there is a stigma with these patients. All these patients are blamed because they eat too much, and most people think this is a self-inflicted disease. However, I must say that we are flooded with food advertisement. So it is not just the problem of people that cannot resist food. It's also the problem of the environment. So I think that there should be a balance between a healthy economy and an unhealthy population. We should have a healthy economy as well as a healthy population. We don't need all the food we are flooded with. We need just good and healthy food, and that's it. Then the second problem that was already been mentioned by Scott is that many people were not coming to our outpatient clinic. They were afraid to come. So what we see now in terms of HCC is a multi-lobular spread HCC that we didn't see in the last 20 years, I guess. So definitely this is going to have a big impact in the future.
I think that both those issues are so important. Let me pick up for a moment on the food issue. One is why we've added a culinary event to help people navigate how to eat in a liver healthy way to our IND panel and portfolio this year, but also why we've taken a really comprehensive approach in terms of our NASH action plan and recognizing that the policy setting for nutrition policy and what people eat and the environment in which people find themselves is as important, given that this is a public health issue, and it's not just the individual who has to struggle through how to live the healthiest and to make the best choices. We have to make the best choices easier for people and more accessible and natural for people to do.
And this is particularly true for children.
Yes.
This was devastating because schools were closed and children were closed in their house eating junk food. That was terrible. And we know that if you start with risk factors earlier in life, then you are going to develop HCC earlier in your, in your maturity days. It might shift like 5 to 10 years earlier, the onset of HCC, having an earlier start during childhood of all these risk factors. We have a problem with childhood obesity in Italy. It is the highest rate in Europe of childhood obesity.
We have that same problem in the US, and I think the realization for people that there are obesogenic cancers, that obesity can drive cancer is a relatively new concept, at least for the public, and something that I think is a really important takeaway from our conversation here today. Dr. Miele, how have you been working with your patients and experiencing liver cancer in the past 12 months, differently from any time before?
Yeah, thank Donna. I think that we, almost all of us, share the same experiences with patients. I had the same feeling with Betta and with Professor Friedman. I mean, we had a reduction of access of patients to our hospital, to our outpatient clinic for the surveillance program. And in particular, obese people were aware about the risk of COVID, so they missed a lot of appointments and just for the scaring of COVID. And this could lead a possible scenario for the next future with an increased spread of liver cancer. Even because, as Elisabetta said a few minutes ago, we had a lot of people that increase the sedentarity, so they don't play any physical activity, they don't eat well, and they don't have an healthy behavior with food, and especially in children. So we expect for the next year, we hope not, obviously, but a possible increase of liver cancer. And as well, I don't know if it's the experience of other of the panelists. We have also to be aware regarding the time that we can spend with our patients, because, for example, with COVID, we have social distancing, a reduction of access or institutional access to outpatient clinics. So we have to increase our availability for this kind of patients to avoid any delay of the diagnosis. Because as almost all knows, the problem of NAFLD is the lack of surveillance, specific surveillance program, and we need to stratify the patient to identify the patient at high risk for liver cancer. This is the real issue, because we cannot provide, we are not able to offer perhaps the surveillance program for all obese people and all diabetic people that we have in our hospitals. But we need to identify the patients to high risk. Mm-hmm. And we probably need to work on this point.
I think that's absolutely important. And I think maybe perhaps in a question or two, we'll talk about liquid biopsies and non-invasive means of diagnosing and stratifying patients by their risk. But I wanted to ask Dr. Shermani, picking up on another point, at the beginning of this pandemic, transplant centers were closed, cancer centers were closed. Patients were thrown really into a state of uncertainty with very serious conditions, and we had to learn how to provide COVID and non-COVID care, often in the same facility. So how have we been getting cancer care back on track for patients, transplants back on track for patients?
Well, I have to say that the experience has been different according to countries and according to, even within the same nation, we had centers who had difficulties to carry on the transplant program. I've been lucky enough to work in a center where we faced a reduction in the transplant during the first wave, especially in March, April 2020. But then we kept on with the transplant activity. But again, as we previously said, there was a problem in terms of access to the hospital for the standard follow-up. We decided to keep the urgent visit, oncological visit, and all the patients on the waiting list. And when it was not possible, we tried to use telemedicine, which is something new, which is something we should get used to. Very difficult because, as we all know, we are used to face-to-face visit with the patient. But unless to lose the patient for the follow-up or to lose some complication of the liver disease, we try also to put in place the telemedicine. And again, it's very difficult because, as we said, we faced a lot of patients coming after the 6 or 12 months with a large weight gain, even in patient on the waiting list, for example, for other etiology, or other than HCC, and so it was quite complex, the relation between a standard follow-up of the patient, the transplant setting, and the COVID as well. As we said before, we also found a significant increase in patients admitted to the hospital, especially in the recent period. I would say in the beginning of 2021, for alcoholic liver disease or alcohol abuse. And I saw a paper recently publishing on JAMA Reports that the authors demonstrated that there has been an increase in alcohol use per day in US as compared to the same period of 2019. So this is something important because, you see the patient admitted for alcohol, you difficultly see the patient admitted for obesity or for some metabolic complication. But again, I'm sure we will see the effect, especially the oncological effect of chronic liver disease in 2022, for example, in the late period of 2021.
Dr. Friedman, how much cancer care can be delivered remotely, either through telehealth or even decentralized trials? So both research and care. How are we starting to use technology to reach patients when there's still so much, I would think, about cancer care that needs to be done in a hospital?
Right. I think that's a critical point, and Giacomo said very rightly that telemedicine came almost out of nowhere, and I think that's one of the silver linings of this whole pandemic is a much higher comfort level for patients and physicians, and it happened to be supported by Medicare and Medicaid willingness to provide full reimbursement to physicians. So there were lots of factors that made, and of course the platforms were there, but not really being heavily used. So the availability of telemedicine was critical, and we were seeing over half of our patients remotely. Now, of course, that keeps them connected to their physicians. It keeps, I would hope, maintaining compliance, but it can't provide screening because that requires CT or MRI, maybe depending on your institution, access to blood tests. And that was really, I would say, impaired, because even for patients who came for screening, the CT rooms or the scanning rooms had to be, thoroughly sterilized between patients. So the volume of patients who could be scanned was dramatically reduced. I will say at our institution, given that the risk of death was so high in patients on the waiting list, we did everything possible and successfully preserved our transplant program throughout, even the depth of our, or the spike that we saw a little bit after Italy in April and May. We did have a couple of deaths in transplant patients due to COVID, so clearly they're at some risk, but it was virtually the only disease that was truly segregated. Other than that, in the height of the surge, we basically had a COVID hospital. That was it. We had 700 beds. We had beds constructed in the lobby. We even had beds constructed in a tent in Central Park across from the hospital. They were all filled. We were, obviously, like Italy as well, we were terrified of running out of personal protective equipment and ventilators. We didn't, but we came close. And so apart from maintaining a sequestered area for transplant patients, every bed was dedicated to the care of COVID patients. It was like nothing anyone had ever seen. Our frontline provider said they'd never been in a situation where every patient in every bed had exactly the same diagnosis.
Wow.
So it certainly created a unique and hopefully unprecedented situation for us. We did preserve transplants. We did dramatically increase telemedicine, but that couldn't substitute for the need for in-person screening and imaging, and often for blood tests as well.
I really want to take a moment and thank the transplant societies and and ASLD and ACG and AGA. I know I was on calls with them. My policy director was on calls with them to CMS to make sure that we had that reimbursement and those waivers to allow telemedicine. And we really are advocating very hard now that we are able to continue that reimbursement for both visual and audio telemedicine moving forward, because for so many patients who previously had to travel, too sick to travel, getting their parents or their children or themselves up and out, in some cases for traveling hundreds of miles to a doctor's appointment, having that telemedicine opportunity was proven so important. Patients, I think, always knew that it was important, but the fact that physicians had such a positive experience with it, and health systems saw 1,000% increases in their use of it. So it's something that we hope will stay as an important complement to the in-person care that we all need. And
one other concession that was relatively unique to the United States was, as you know, licensure is regulated by individual states. And if you want to see a patient in Connecticut and you live in New York and have a New York license, you can't. You have to have a Connecticut license if the patient is in Connecticut. So during the crisis, they waived the requirement that you be licensed in the state where the patient was living and taking the telemedicine call. And I don't know, that's unlikely to be conserved. So
we have raised that issue, and so we are actively advocating for that change to persist. Because you're right, otherwise, patients would otherwise cross those boundaries to receive care, to come to a Mount Sinai or other facilities, and so it doesn't make sense for the care to be so constricted. And I've been arguing for that since I was on the HIT policy committee.
Right. It's somewhat of an indictment of the cumbersome and terribly complex way that care is organized and delivered and reimbursed here in the United States. In many ways, I'm quite jealous of Italy in particular, and all the major European countries that have single-payer healthcare. So you don't have to encounter these absurd obstacles in terms of access to care.
But you're absolutely right, and some obstacles, though, still do exist. So I want to talk about those. Elisabetta, what other challenges, even moving forward, apart from COVID, to providing the best care to your patients with liver cancer?
Yes, I think that in this field, telemedicine may be a great opportunity, because one limitation is the lack of coordination, cooperation between general practitioner and other specialists who share the same patients. We only see the tip of the iceberg. We often see patients when it is too late, just because they come out with an unresectable cancer or something like that. This is because we still are not used to have a multidisciplinary approach to these metabolic patients. The patient is basically the same and should be seen by the hepatologist, by by nutritionists, by general practitioner, by hepatologist, and so on. And this is, first of all, a matter of awareness of the patient. That should be informed that if you are diabetic, a possible outcome of type 2 diabetes is cirrhosis and liver cancer. Awareness of the society, specialty society, for example. I can see that even in the last published document, international documents on type 2 diabetes, liver-related complications are not mentioned at all. And if you look, for example, at the WHO webpage on obesity, and you go through and look at the complication of obesity, again, liver disease is not mentioned at all. And this is a big gap to be filled, because both the patients and the other specialists should be aware of this risk and should recognize the risk. It is not just a problem of therapy. Of course, now that we are going to have some active molecule on NASH, this is great for prevention of NASH with fibrosis, and so prevention of hepatocellular carcinoma. But apart from the therapy, which is obviously important, a patient must be aware of what can be his destiny or her destiny.
I only smiled because we do have WHO represented on another panel, and so we will be asking that question and hoping that we can work with them to correct that exact issue. But I want to draw on 2 points that you mentioned. One is the fact that NASH is too often first diagnosed when someone ends up in a cancer ward or with a cancer diagnosis or a transplant diagnosis. And so we need to walk that back. So their NASH diagnosis is made when they're in primary care or in the endocrinologists and or even with their lipid specialists, but further upstream, well before they get to oncologists. And I think that's a very important point. And then I hope we'll also discuss, and maybe Dr. Miele, I'll ask you about, multidisciplinary tumor boards. And so in the treatment with someone with liver cancer, bringing in the various disciplines that need to be involved to provide, best practice care to liver cancer. So perhaps on that point, Dr. Miele, on the multidisciplinary way of treating liver patients.
Yes, we were quite lucky till the COVID, because we started a multidisciplinary board even for NASH, so for a patient with fatty liver, and we involved several specialties from our hospital. So we had a really in-depth discussion for single cases, and sometimes we identified very early patient with unknown cirrhosis. Mm-hmm. This is a problem. I mean, I fully agree with Elisabetta, because there are a lot of specialties that usually see patients with NAFLD and cirrhosis, but they are not aware regarding the real diagnosis of those patients. A lot of consultation that we have is just regarding hypertransaminasemia, an abnormal liver function test. But the other specialists completely miss, for example, the low platelets number. That is a very simple, a very easy marker that can raise the awareness regarding advanced liver disease. And on those patients, we are able to focus our attention. Moreover, we also have in our hospital a multidisciplinary team, a multidisciplinary board on liver cancer, and we never stopped even during the COVID pandemic, even during the first wave. We kept the liver cancer activity during all the COVID period, just for assuring for patients with known liver cancer the possibility to the best approach. But the problem is to make an early diagnosis in patients with NAFLD, because patient liver cancer, we know that may arise even in the simple fatty liver, and we have no strategy to identify this kind of patients at the moment.
You know what Luca and Elisabetta are pointing out is so very important. It's probably true that 90% of the patients with NASH or more are not in the hepatologist or gastroenterologist offices. And we don't have national or even international guidelines for screening routinely, particularly among diabetics, which I think Elisabetta rightly pointed out are especially high risk. And perhaps one of the reasons is because apart from weight loss and exercise, we have no actionable information that comes from a diagnosis of NASH. And I'm almost reluctant to admit that probably when there are approved therapies, we'll have the additional benefit of the companies promoting those therapies joining us in trying to develop standardized screening regimens to detect asymptomatic disease. But this is a huge problem. And as Elisabetta said so aptly, we're really just seeing the tip of the iceberg. And all epidemiologic studies indicate that this is a disease that is widely prevalent and growing.
You know, the dynamics of creating and transforming a field. You know, I remember when GLI first started in NASH in 2017, and made the decision that we would launch at the School of Public Health and invite groups like the American Heart Association and the Endocrine Society, and really enlist our diabetes and cardiovascular colleagues to set the expectation from the start that NASH was going to be a much larger tent and would need a much larger, force than any other challenge I think we've faced in just the liver community by itself. And I think NASH will be the stronger for it. And also, I think liver health as a whole will be better for having been more collaborative and sort of raising the attention for internal medicine, primary care, diabetologists, and cardiologists that this is their disease too. We liver patients are in their care already, and there needs to be integration of a liver health discussion alongside heart health and brain health and obesity management and all of these things. And we're going to have to try to make it easier for them to do that within constrained time and resources. But it needs to happen. And so that is really one of our ultimate goals, not only of International NASH Day, but a lot of the work that we're doing to really get liver health embraced and integrated into just the care of people and every patient. Because as I point out, if you have a liver, and everybody does, except for those of us who went through transplant for a few moments, you're at risk of some type of liver disease. And so it really needs to be an all hands on deck, every specialty, problem. Whether or not there is a drug developed as we hopefully there will be soon, but they're getting the patients connected to care, getting them screened and active management, helping to provide them the supports that Elisabetta, that you talked about, dietitians and other parts of the team, bariatric surgery, and the things that we can do now, we should be doing now, or at least have patients in care, so that when a treatment for an indication is available in other countries besides India, that they'll be ready. We'll all be ready to immediately add that to our armamentarium.
And that's why what you are doing is so important. I mean, GLI has filled a huge vacuum of having advocacy both nationally and internationally for this disease. And that in the end is so impactful in the context of legislation, national policies, screening guidelines. So thank you. I know you weren't fishing for a compliment, but I still want to offer one, because Global Liver Institute is really addressing a huge unmet need.
Thank you. It is my honor and privilege. I wouldn't be here today, 26 years post liver transplant, without all of the hard work and innovation of everybody on this panel and on the other panels throughout this day. And so to be able to give back and to make sure that other patients have access to this innovation and these levels of care is really a privilege for me and the entire team at GLI. And I know all of our team in Italy would love to thank this panel that we really had not had access to before, to really create a global community for liver disease, because it is a global problem. So I wanted to maybe leap off next to maybe starting going backwards with Dr. Germani. How can, when we talk about treating patients with NASH, with cancer, a question that patients often have and are discussing with their physicians are, am I at a stage where transplant is still an option, where surgery is still an option, or is drug therapy? And so how do you start to talk to patients about understanding, what of the now many options that we have in liver cancer are appropriate for them, and have them navigate through an increasing number of choices?
Well, we have to start from the point that we should firstly know what's the best treatment for that patient according to degree of liver disease, characteristic of the tumors. So we should have a sort of few options when we go through. And as we said before, we usually discuss patient during the multidisciplinary team, the oncological one or the standard one, but we always discuss each case with the surgeon, with the radiologist, with the oncologist. So it's not just the single doctor choice, first of all. And secondly, according again to the stage of liver disease and according to the stage of HCC, we talk with the patient. We tell the patient which option we have and what can be the future after the specific treatment. Obviously, sometimes we decide to go straight for liver transplantation, and here obviously we can discuss the whole day about criteria for waiting list of patients with HCC, because each center has different criteria, even within the same nation, even within the same region, here in Italy, for example. But again, we talk with the patient, and we ask the patient what's his or her thought about the treatment, obviously the fear of recurrence or failure of the treatment. And sometimes they come already saying, I'm here for a liver transplant evaluation. Nowadays, Dr. Google allows everyone to get information that sometimes are good, sometimes are completely wrong. But again, it's not like 20 years ago patient sometimes comes already with a lot of information, and you have to go through them and explain them. But again, as we said, sometimes patients with NASH and HCC, they arrive at our attention at a very later stage, and with large tumors, sometimes difficult to treat, and sometimes they need transplantation, and this is why NASH is one of the greatest cause of HCC in patients on the waiting list in US, in Europe as well, and I can tell you also in our center, at all different levels. So I mean, this is our strategy usually with the patient.
You know, at the time of this airing, it would have been a month or so since my testimony before the U.S. House of Representatives on organ donation accountability and policy. It seems to me, though, that it is a realistic goal if we had higher performance across all of our organ procurement organizations, that, you know, at least in the U.S., and we should look in the best practices of other countries, you know, there are fewer than 12,000 people who are waiting for a liver transplant right now. And I can't seem to think that we couldn't eliminate that list. And so rather than a preoccupation with MELD and PELD scores, with points and exceptions, we should just find a way to provide everyone who needs it with a transplant. And so that is our goal for GLI, and we look forward to working with that in every country in which we have partners. But until such time, we know that you were engaged, all of you, in both clinical care and research. And so maybe Luca and then Scott, I'm going to ask you how you help patients make the decision between, should I be in a research study or should I move directly to some type of first-line therapy? So Luca first, maybe.
Well, actually, even for the trials, for the experimental therapy, we discussed this opportunity in our board. So in this case, we shared the decision to address the patient to the trial. Actually, I think that we have also to reflect regarding the problem of obesity and liver transplant, because without any doubt, liver transplant is the main choice for liver cancer if it's treatable. But you know, even because patients come very late at our attention, this is a problem. But the other problem is also that sometimes the BMI does not allow a safe transplant program. And this is a big issue in which I think that the Association of Patients could try to make a more decisive empowerment of patients.
I am very glad that my Peloton bike arrived before I was locked in here. If I had not if I didn't have the opportunity to for intense exercise here at home, I would definitely have, I'd be keeping a few more COVID-19 pounds that were mainly in pasta, since I don't bake sourdough bread like the rest of America. But I was, raised, in part by Mrs. Alphonse Scapini, who taught me how to make pasta from scratch as a child. I was glad for the opportunity for safe exercise. And I think that as we partner with the College of Sports Medicine and try to reinstate recess and activity for everyone from children through seniors,
Yes.
Playing on the playground or hiking through the woods, activity has to be, and let's not call it scary exercise or everything, but activity has to be a key component of this, along perhaps with the patients that are an issue for you all, bariatric surgery, with the support of dietitians and really, weight loss medications, perhaps, and all the tools that we have to have someone, reach if not an optimal, BMI or lean body mass, at least something that will make them safer for the surgeries that will save their life, and then something that they would need to engage in, afterwards, constructively and sustainably.
Yes, exactly.
Absolutely. So Scott, research, and
Right.
tell our listeners and our patients what research in a NASH trial or in a liver cancer trial looks like.
So you raise such a critically important point, Donna, because the evolution of therapy for cancer in general and liver cancer in particular is not possible without clinical trials. And to me, it's an obvious choice because the current therapies are not effective or not sufficiently effective, and without progress that comes through clinical trials, will never advance to the next generation. A very good example is a major paper that appeared in the last month in Nature that discovered that the behavior of the immune cells within the liver in NASH are quite different, NASH cancer, are quite different than the behavior of immune cells in cancer that arises from hepatitis B and C, for example. To put that in a little context, as you and the listeners probably know, there's been a revolution of so-called immuno-oncology drugs or checkpoint blockers that cripple the immune resistance to cancer treatment. PD-1 antagonists, for example, and some of them are just widely available and effective for other cancers like lung. And so they've been applied now to liver cancer. And the paper that I'm referring to, and also a companion paper that I was part of that's in Press and Journal of Hepatology, discovered amazingly that those checkpoint inhibitors work much, much better in liver cancers associated with Hep B and Hep C than in liver cancers associated with NASH. That has profound implications for how to strategize and prioritize therapies in patients with NASH. It also underscores how valuable it will be to examine the tissues and continue to yield more insights through research studies that, of course, require the cooperation and participation and consent of patients. Without those patient consents, we can't get the tissue, we can't assess the effect of drugs, we will not make progress. And because the existing treatments are not adequate, at least medical treatments, as opposed to transplant or resection, the medical treatments have such a long way to go that it's, to me, absolutely urgent that patients with liver cancer not only consent to treatments, but seek their care in leading centers that can advance those treatments. It's just that important.
And what can we do to help an increasing number of patients participate in those trials? How do they hear about them? Are there ways that they can participate, hybrid trials, or ways that they can participate them at least in part in conjunction with their community cancer centers or care at home, so that we can get as wide and diverse a population of patients. Perhaps if they don't live really close to an academic center, how can we make sure that we get the broadest participation of patients possible in liver cancer and NASH clinical trials?
Well, I think you can imagine it's leveraging every potential resource for communication and dissemination you can imagine, from social media, of course, clinicaltrials.gov, educating the providers, educating local oncologists, making sure and doing everything we can to disseminate information about available trials beyond just the orbit of our immediate patient populations, but also the communities that are diagnosing these patients. Not a single answer, but everything would help in terms of, and of course, organizations like yours that are so vital as a clearinghouse for patient-based and patient-focused information to get them to the right centers to test new drugs.
We'll definitely be adding more clinical trial research information and curation of trials for patients to our website moving forward through this year. And as we start adding support groups at both virtually and centers, certainly making sure that not only the availability of trials, but what it's like to participate in a trial is something that will have our peer mentors and supporters work with patients on. I've made it very public that I participated in clinical trials. Even now during COVID, I'm participating in 2 vaccine effectiveness trials, one for transplant recipients and one for inflammatory bowel disease patients, which really just require, me going downtown and getting some blood work and sending them off electronically to both. So I think that it's important for patients who are participating in research to make that known, so it's demystified, and then being able to answer questions about, what is an informed consent, and walk through, okay, these are the number of days that you may have to participate in, in a trial, and so this is what it means for getting childcare or taking off work, and so I enjoy working with the sponsors of trials to make things as patient-centric as possible, as much as I enjoy talking to patients about, how important it is to participate, and, you really can fit into your life and how important it is.
This is a great gift from our patients to us and to the field. I don't take it lightly in the sacrifices that patients have to make that may hopefully help them, but certainly will help those who follow. It's a wonderful gift, and I think for our part, we need to reinforce how valued it is and how much we appreciate patients like you, Donna, who agreed to these to participate in a number of different research trials to advance the care of patients who follow.
I'm only alive today because I've stayed sort of one step behind the innovation. I know in IBD, certainly I've been on every mode of therapy that has been developed, and just lucky enough to live at a time where they come out just before I need them. And so for patients who are considering participating in clinical trials, certainly for many it's a way to get state-of-art care themselves, but thinking about the next patient or the next patient family behind who could benefit from what's discovered, even the lessons learned from a quote-unquote unsuccessful trial is still helpful information for the field to have. And so I could not be more forceful, if you couldn't tell, in my support for research and clinical trials. And so often patients are so anxious to start something, and I understand that, but to have conversations with their physicians about what are all the steps and what's the entire roadmap, so that I don't make a decision at the beginning, when I'm treatment naive, as they call it, that will foreclose my opportunity to participate in a trial maybe a little bit down the line.
If I can say something about it, I think that what we said is very important. I think we have to educate and inform not only patients, of course we have to inform them, but we have to educate also doctors working in local hospitals, because what we see a lot, and not only for HCC but also for HCC, is a late referral of patients with liver disease. And sometimes, in case of HCC, obviously you close to the patient, you close the opportunity to treat the patient with some with some techniques, and then you have to move them straightly to the transplant, or sometimes not even the transplant. And this is because sometimes in local hospital they treat the patients because as they are used to do it. And so I think that the education and the information of patients and also local hospitals is crucial for improving the care of these kind of patients.
Absolutely. And this gives me thoughts for how we expand our Liver Cancers Council to make sure that we are, embracing everyone who has sort of an early touch, potentially, of the cancer patient, whether within different areas of your hospitals or, different, parts of the community, to see this connection, because it is the saddest thing for me to hear, and I'm sure for you all as well, that a patient is diagnosed so late that they can't take advantage of all the new treatments and options that are now available for them. So maybe on this point, as we start to close, what is the one takeaway from this conversation in NASH and liver cancer? What do you most want your physician colleagues to know and do? And maybe Elisabetta, I'll start with you.
Well, first of all, pay attention to liver disease, because liver disease is one of the most overlooked disease anyway. This is because it is a silent disease. It has no symptoms. And when the symptoms comes, it's too late. So, and very often people don't think to liver disease as a possible complication of, let's say, obesity and type 2 diabetes, as I already mentioned. But in general, liver disease is surrounded by stigma, which is mostly related to alcohol. So people with liver disease are associated with alcohol abuse. And we know that these poor NAFLD patients in the beginning were thought to be unrecognized drink addicted, because no one, 30 years ago, I remember that we were seeing some nice people with these alcohol-like livers, and everyone was thinking, these people is not telling us the truth. These people cannot be sick like an alcoholic liver disease and not drink a drop of alcohol. So there is a double stigma. I mean, liver disease equal alcohol, and all liver disease are related to alcohol. And if not alcohol, is food. And anyway, you have to be blamed because you eat too much. So this is something that we should overcome. I mean, take into account liver disease. It is an important cause of death, particularly in the earlier age. If you compare to type 2 diabetes, for example, most deaths are in the 70s or 70s, 60 or 70s, while in liver disease, these are 10 years or 15 years earlier compared to diabetes.
Thank
so
you.
It hits particularly younger people.
It does. It absolutely does. And someone who went from diagnosis to transplant with my autoimmune disease, liver disease in 2 years, I know how quickly this can progress. And until we really know who are fast progressors and slow progressors, we need to treat everyone with urgency as well as compassion, given the stigmas. So, Luca, your last words to your physician colleagues?
Yes, I fully agree with Beth. I will say just check your liver if you have some risk factors for a progressive fatty liver disease, because we can say over the alcohol and viruses, there is also something more, because we should be aware that even fatty liver may progress to liver cancer. So be aware.
Excellent. Giacomo?
Well, again, I think the cooperation between specialists is crucial with this kind of disease, and also increase the awareness in patients, at least in those patients with diabetes or patients with obesity, that they could have a liver disease. So they should know that they should ask their physician, their GP, to do at least a gastroenterology, a pathological check, because sometimes could be too late.
Thank you. And Dr. Friedman, the last word.
I have little to add to my esteemed colleagues. It's awareness, 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 awareness by patients who seek the best care, the best doctors, the most specialized treatments, and awareness among physicians, particularly the vast majority of whom are internists, primary care doctors, endocrinologists, also OBGYN, which serve as primary care doctors for many women. They need to be aware. Type 2 diabetes should be a trigger to immediately consider liver disease, at least perform non-invasive screening, and if in doubt, refer to a specialist who has more experience. Otherwise, we're going to be missing these early disease patients that my colleagues have so elegantly defined.
Thank you. Thank you to you all. I think we've given both awareness and hopefully spurred people to action today with this GLI International NASH Day panel on NASH and liver cancer. So thank you, everyone. And you can find information about all of our International NASH Day panels, all of our resources and special events on hopefully every platform or social media. We're at Global Liver on Facebook, Twitter, at Global Liver Institute on Instagram. Please use the hashtag NASH Day, and thank you so much.
Thank you.
Thank
Thank
you.
you.
Great work.
Bye.
Bye-bye.